The next chapter now deals with skin surgery. We're going to talk about cancers of the skin. There are 3 of those: basal cell carcinoma, squamous cell carcinoma, and melanoma. They all have a few things in common. They are related to sun exposure. So the typical patient that gets either a basal cell carcinoma, a squamous cell carcinoma, or a melanoma is frequently a blonde, blue-eyed, red-headed, fair-skinned individual who by virtue of his occupation or hobby is out in the sun all day long and who lives in a part of the world where the sun shines all day long. And that sun exposure leads to the development of any of these tumors. Let's review each of these. Vignette number 11, a 65-year-old West Texas farmer of Swedish ancestry has an indolent, raised, waxy 1.2 cm skin mass over the bridge of the nose that has been slowly growing over the past 3 years. There are no enlarged lymph nodes in the head and neck. The only one of the cancers of the skin that may present that way is the basal cell carcinoma. Let me continue though, because the basal cell carcinoma can also present as an ulcer. So let me continue. Eventually, by the way, I'll save the management until we've talked about all 3 types. So here's vignette number 2. A 71-year-old West Texas farmer of Irish ancestry has a non-healing, indolent, punched out, clean-looking 2 cm ulcer over the left temple that has been slowly becoming larger over the past 3 years. There are no enlarged lymph nodes in the head and neck. This second one is also basal cell carcinoma, but it might be confused with squamous cell carcinoma of the skin, because this one that we just read is an ulcer that doesn't heal, and so is the squamous cell carcinoma. But there are some differences. The basal cell carcinoma grows very slowly. So the history of a basal cell carcinoma is going to be many months or even a year or 2. Squamous cell carcinoma grows a little faster. Basal cell carcinoma typically does not metastasize to lymph nodes, so the presentation will not include big nodes, which squamous cell carcinoma might have. But there is an even better guideline. Most, not all, but most basal cell carcinomas occur above a line that you might draw across the mouth. So upper lip and upper face, that's where you find basal cell carcinomas, whereas we find most squamous cell carcinomas of the skin below that line, lower lip or below. So this one is most likely the basal cell carcinoma. Now let me read vignette number 3. A blonde, blue-eyed, 69-year-old sailor has a non-healing, indolent 1.5 cm ulcer in the lower lip that has been present and slowly enlarging for the past 8 months. He is a pipe smoker and he has no other lesions or physical findings. Well, now, by the location and the time frame, this is 8 months in contrast to the previous one that was 3 years. You have good reason to suspect this is a squamous cell carcinoma. We'll talk about the management in a minute. Vignette number 4. A red-headed 23-year-old lady who worships the sun and who happens to be full of freckles consults you for a skin lesion on her shoulder that concerns her. She has a pigmented lesion that is asymmetrical with irregular borders of different colors within the lesion and measuring 1.8 cm. A mnemonic we often give to our students to remember which pigmented lesions should they suspect of being a melanoma is A, B, C, D. Because the lesion is asymmetrical, the borders are irregular, the colors within the lesion are variable, and the diameter exceeds 1 cm. There is another alerting signal that may say to you a pigmented lesion is in fact a melanoma. Let me read vignette number 5. A 35-year-old blonde, blue-eyed man left his native Minnesota at age 18 and has been living an idyllic life as a crew member for a sailing charter operation in the Caribbean. He has multiple nevi all over his body, but one of them has changed recently. When a long-standing pigmented lesion changes, any kind of change, it grows, it ulcerates, it changes colors, it changes appearance, whatever, we think of melanoma. And in fact, some people have gone back to the A, B, C, D mnemonic and added an E for evolution. So in this new incarnation of the mnemonic, asymmetrical, borders irregular, colors different within the lesion, diameter more than 1 cm, evolution of a long-standing lesion. Now let's talk about management. For all of these, the one we suspected was basal cell, the one we suspected was squamous cell, the one we suspect is melanoma. What we do is a full thickness biopsy at the edge of the lesion. It is imperative that we give the pathologist the tumor, the boundary between the tumor and the normal skin, a little piece of the normal skin. My students often obsess about what instrument to use for the biopsy, whether it should be a punch biopsy or done with a knife, and that's really quite irrelevant. The important issue is that it be not done at the center of the lesion, but at the edge. That it be full thickness, that it include ulcer and nearby normal tissue with a boundary between the two. Now the pathologist calls back eventually and says that biopsy that I looked at is a basal cell carcinoma. All we need is a limited excision and a very small margin, provided the margin is free of disease, is enough. We don't need to do a big resection. The pathologist, on the other hand, says that is a squamous cell carcinoma of the skin. Now we need wider margins, preferably 1, perhaps even 2 cms if we can do it. And we need to pay attention to lymph nodes. They may be involved, and we may need to do a sentinel node biopsy if there is any question about them. But if the pathologist were to say, the biopsy that you sent me is a melanoma, and said nothing more, you would ask immediately, wait a minute, how deep is that melanoma? Because what we need to do for a melanoma and the prognosis of a melanoma depends on the depth of that lesion. If that melanoma is very superficial, if the melanoma is 1 millimeter or less in the depth, this is what we call a superficial melanoma. All you need is a margin-free local excision, and the patient will be cured most likely. If, on the other hand, the lesion is more than 4 millimeters deep, then that's a deep, invasive melanoma with horrible prognosis. And the intermediate depth, which is between 1 and 4 millimeters, is the type of melanoma that benefits most from aggressive therapy. Remember, the superficial doesn't need aggressive therapy. The one that is more than 4 millimeters is probably going to die no matter what we do. The one in between, we are aggressive, we do a wide local excision, we look at the lymph nodes, if necessary, do sentinel node biopsy and go after the nodes. So the next 2 vignettes refer to some very peculiar behavior on the part of melanomas. Melanomas can do things that other malignant tumors don't do. One of them has to do with where do they metastasize. They go to the usual places, nearby lymph nodes as well as liver, lung, brain, and bone. But they also can go to the weirdest places you can imagine. They can metastasize to the wall of the left ventricle, they can metastasize to the wall of the duodenum, they can go anywhere. And the second weird characteristic is melanoma doesn't have a predictable timetable. Sometimes we see a patient with an invasive melanoma and 3 months later, after appropriate therapy, he's full of metastases everywhere and dies. And the next patient we see with an identical tumor for which we do the identical therapy may go 20 years free of disease and then explode with metastases everywhere. So the timetable of a melanoma is unpredictable. So let me read you 2 vignettes that illustrate those 2 behavior patterns. Vignette number 6. A 44-year-old man has unequivocal signs of multiple liver metastases, but no primary tumor has been identified by multiple diagnostic studies of the abdomen and chest. The only abnormality in the physical examination is a missing toe, which he says was removed at the age of 18 for a black tumor under the toenail. That was a melanoma. Years and years went by without evidence of the disease, and now melanoma is growing rapidly again. Vignette number 7. A 32-year-old gentleman had a 3.4 millimeter deep melanoma removed from the middle of his back 3 years ago. He now has, and the vignette is going to give you a tumor in a weird place. He now has a tumor in the wall of the left ventricle or the wall of the duodenum or the ischiorectal area. You can make a connection between the two. This weird location of a tumor is probably metastatic melanoma, because melanoma is known to do that. And we tend to be aggressive in our management of these. We resect those metastases if we can, precisely taking advantage of that unpredictable timetable. We are hoping that this may be the next patient on whom, after we resect the metastases, he'll go another 20 years before he has further problems. Well, let's look at a couple of pictures then to wrap up the skin section. Here is a picture of a basal cell carcinoma. I cannot tell looking at this where this is in the body, although I gave you the rule of thumb. They are typically above a line drawn across the lips. And here are pictures of melanomas, and you see pretty much all of the features illustrated we've talked about. Irregular borders, different colors within the lesion. Now, we don't have a scale there of the size, but I would assume they are more than 1 cm in diameter. So we have the asymmetrical, irregular borders, the different colors, the diameter. And that is the end for the skin surgery chapter.